Number 11. I always smile when I see number 11 because this ought to go without saying, but it has to be said often. Number 11 reminds us, agree on the problem before moving to a solution. Now, in the abstract, that sounds like an obvious statement, but let's talk about it in the concrete instance. You're reading down through a Step 2 CK question, and you realize as you're reading through the clinical case exactly what's wrong with this patient. You recognize the diagnosis, you know immediately what's wrong, and you know exactly what has to be done in order to treat this patient. There you see the option for treatment, and when it says what should the physician do next, you pick the right treatment, you know it's right, you've learned it's right, and you know that's what the patient needs, and you just got the question wrong. Because they didn't say what you do to treat this patient, they said what should the physician do next. And if you're thinking about moving towards treatment before you've had a conversation where the patient fully understands their diagnosis, you've clearly got this wrong. The patient must have a clear and fairly precise understanding of what it is that's wrong before treatment is even a part of the discussion. And by the way, when you're talking to the patient about their health condition, let's avoid what I like to call the 101 discussion or presentation about the patient's condition. Many physicians learn a simple canned presentation of a couple minutes by which they'll explain a patient's condition to the patient. You don't want to simply give them the canned presentation because often you'll discover the patient knows some or maybe even all of what you're going to say already. So you don't simply tell them what they have and then explain it. You name the diagnosis, you give them a sense of what you're talking about, and then you say, now, what do you know about blank? In other words, it's a conversation, not a monologue. You want to hear back from them so you have a sense of what's the appropriate information to provide to them. If they know it already, they don't need to hear it from you. This may sound like a trivial issue, but it's not trivial to patients. When you ask people why they've left physicians they used to see, one reason often cited is my physician keeps talking to me and doesn't listen to me. My physician tells me things I know rather than finding out that I already know them. Agree on the problem, make sure the diagnosis is clear before we move on to discuss the solution. Number 12. I smile again when I see number 12 because, again, this sounds common sense and matter of course. Be sure you understand what your patient is talking about. But the reason why this rule remains is often, when you're honest, you don't understand what your patient is talking about. Patients come in to see their physician and sometimes say things when they're angry or emotionally charged. And if the physician's honest, you don't really understand what is being said. You understand the patient's angry, you understand they're emotional, but you don't understand what they're talking about. You have a 43-year-old woman diagnosed with diabetes, been treating her for the diabetes over the last 3 years. You walk into the office to see her, and she's sitting there, and it says angrily, ugh, this treatment just isn't working. I don't know where you came up with this. This just isn't working at all. To which the physician's best reply would be, well, this one we're not going to express empathy and give control, because you know why? We don't understand what she's talking about yet. The right reply to this patient has to be getting information. When she says not working, what does she mean? When she says, not good for me, what is she talking about? And so the right reply has to be, tell me more about how this isn't working for you. Patients often use words emotionally charged, even aggressive towards us, but the words are general. We don't understand the specifics implied. Words like problem, trouble, phrases like not working, words like difficulty, we don't really understand what they mean, and so the right answer must be to stop and ask for clarity so we know what the conversation's actually about. Number 13, patients are indeed the key decision makers, but patients do not get to select inappropriate treatments. Patients get to select from the menu you provide, and if it's not on the menu, you will not provide it. Now, this is an issue that happens increasingly in the real world, because the pharmacy companies have discovered that they can do better advertising directly to patients as opposed to directly to physicians. And so increasingly, physicians say patients come into their office demanding the treatment that they saw on television or read in a magazine, perhaps. It was 6 months before I knew what Nexium was. I just knew I needed to have it. I knew I needed that purple pill. Because if you remember, way back when this ad first came out, all they told you was, you need this. They never told you what it was for. I want you to reflect on all the people who went to see the physician saying, I want that, when in fact it's a wholly inappropriate treatment. And if it's wholly inappropriate, you will not agree to provide that treatment to your patient on the exam. In the real world, when patients demand treatments and we say no, we demur, they usually say, well, I'm going to go find a physician who will do it for me. And you know what? They probably will, but at least it won't be you. Patients get to select from the options you provide. If it's not on the list, you will not provide it. You present the menu. If I present you a menu in a Chinese restaurant and you order Italian food, it's not going to happen. It's the same metaphor here. You provide the options, they make the choice. Number 14, be sure who your patient is. This is a relatively short but important reminder. Usually, in most medical situations, it's clear who the patient is. But sometimes, if you're not careful, you can lose focus and become confused. You're treating a 3-year-old boy for severe otitis media. All treatment decisions and all information about his health status are being provided to you by his caring and adoring mother. Who's your patient? The 3-year-old boy. Don't lose focus and focus on the mother. It's the 3-year-old boy who should have your attention and you should be directing your comments to. You've been treating an 87-year-old woman in a persistent vegetative state over the last several years. All treatment decisions are being made for her by her caring and adoring son. Who's your patient? The woman in the vegetative state. The son who you interact with, I know that's the person that's available to talk to, but that's not your patient. The only reason that person matters, remember, is the degree to which you believe he represents the wishes and the will of your patient. If that ceases to be true, he doesn't matter at all. Number 15, never lie. Never. We made this rule 2 words in the vain hope you'll actually remember it when you're in the middle of the exam. Never lie. You will not lie to patients. You will not lie to family members. You will not lie to colleagues. You will not lie to insurance companies. Never lie. Patient says to you, I accept I have cancer, but my wife, she's not going to be able to really tolerate that news, doctor. If she asks you what's wrong with me, just tell her I have an infection. A couple of days later, the patient's wife stops you in the hospital corridor and says, look, doctor, what's really wrong with my husband? He won't really tell me, and I feel like I have the right to know. What's really wrong with my husband? To which the physician's best reply would be, what? How about, I'm sorry, I can't discuss your husband's condition with you. I know that feels good, but it's simply not a good answer. The reason is it's felt to violate confidentiality. By saying you can't discuss his condition, you're actually implying that he has a condition, and even that is a breach of confidentiality. What you should say to her is something along the lines of, your husband is fully informed about his health issues. He can tell you anything that he thinks he needs to know. In short, you'll send her back to the husband. Information must flow from patient to family, never through family to patient. You must send the family member back, and the patient can tell them whatever they want and can withhold whatever they want. What you will not do is lie. What you will not do is say, he's fine, he's going to be okay, he just has an infection, or any one of a number of platitudes that we sometimes resort to in the real world. Your patient comes to you, they've just been diagnosed and they're now undergoing treatment, and they say, Doc, this diagnosis you wrote down on my chart, my insurance company doesn't cover this. Now, I looked it up in the ICD-10 codes, and instead of 0.8, if you make this one 0.9, they cover that. Here, make the change. You will, of course, not make the change, because making the change is a lie. In this context, making the change is worse than that. It's considered fraud, and you can actually go to jail for this. So, wait, if I don't make this simple change, then how's my patient going to get, coverage, and therefore how's my patient going to get treatment? Well, I don't know how they're going to get coverage, but I do know how they're going to get treatment. You're going to provide treatment, and you're not going to get paid for it. If you're thinking about how do you get paid, you've lost focus. Options you might see in questions such as that, where you're going to petition the insurance company to provide coverage for this particular issue, that's simply not the right answer. Options where you're going to get the physicians in the geographic area together to petition the insurance company so that all patients with this condition can get coverage in the future, not the right answer either. Why? You've lost focus. You're focusing on how do we get paid. You've lost focus where it should be, how does the patient get care? Never, never lie. Number 16. Now the rules get interesting. Number 16 reminds you to accept the health beliefs of the patients and, I hasten to add, deal with them on that basis. Use your patient's language. Call things what they call them. It is not your job to convert them to the Church of Pathophysiology. It is not your job to make sure they use the right Latin or Greek derivative name for whatever is wrong. It's your job to communicate with them in a way that they understand, which often may seem foreign to you, but that's okay. It's about what's comfortable to them that matters. Deal with them in the way that makes sense to them. You have a patient, a 56-year-old woman, who comes to see you with severe GI distress. You recognize immediately what is the pathogen involved, and you have in mind the exact correct antibiotic that will provide fairly timely and immediate relief to this woman. Before you can talk to her about the treatment recommendation you have in mind, or indeed what her diagnosis is, your patient says to you, "Look, doctor, I know what's really wrong. My next-door neighbor, she put this voodoo curse on me." To which the physician's best reply would be, "No, I'm sorry, you don't have a voodoo curse. You have a peptic ulcer. Let me explain what's involved here." Of course not. Because you're now trying to get her to see things through your eyes rather than you seeing things through her eyes. If she truly thinks it's a voodoo curse, she's going to decide you don't really understand what you're talking about. How about you say to her, "Well, I think there might be a different healthcare provider who might be able to help you with this more than I can." Again, of course not. She's your patient. You're the doctor, she's the patient. You're clearly in a physician-patient relationship. You must provide care. How about, "Would you like me to talk to your next-door neighbor?" Of course not. The issue is not about getting the next-door neighbor involved. How about, "I'm glad you came to see me. I've had great success dealing with just this kind of voodoo curse." Yes, that's the answer. Wait a minute. I call this a voodoo curse. Isn't that a lie? No, I'm simply using her language. She calls it a voodoo curse. I call it a voodoo curse. That's all that's happening here. I still have in mind the exact issue. I'm still going to talk about it the exact same way. I'm still going to provide the exact same intervention. I'm just going to call it a voodoo curse when I do so. All we're doing is using the language the patient uses so we can help have things make sense to the patient. Now, I know this might seem strange, but we do this all the time in the real world. When your patient has a myocardial infarction, you don't sit down with them and say you've had a myocardial infarction. At least I hope not. You say they've had a heart attack. And if you're good at all at doing this, you get out the picture of the heart and you show them exactly where the problem is in terms of the anatomic profile. That's the way to have the conversation. Making sure you approach the patient, calling things what they call them, seeing things through their eyes. Number 17. Accept the patient's religious beliefs and participate if at all possible. The reason for this injunction is clear. Research suggests that when physicians participate in the religious beliefs of the patients get better sooner, are discharged from hospital sooner, and have lower infection rates. And whether that's the providence of God or placebo effect, I don't know, and I don't care. Your focus is on getting better medical outcome. And since we know from fairly voluminous research at this point that this provides better medical outcome, the question is not why should I do that? The question is why wouldn't you do that given the weight of the existing evidence? Suppose you're an atheist. You don't believe in God. You think people that believe in God are stupid. And your patient, an 88-year-old Catholic woman, talks to you prior to the surgery you're going to do the next day. The woman asks you to get down and pray the rosary with her, a Catholic prayer ritual. What's the right reply on the part of this atheist physician? Well, that's obvious. Get down and pray the rosary. It's not of your religion, but that doesn't matter. It's of her religion. And so you're going to participate in that religion. The right other options you see that says, I'd be happy to have one of my other residents who's Catholic pray with you, not correct. The option that says, I'd rather have the hospital chaplain come in and pray with you, not correct either. She's asked for you, so it's going to be you. Patient comes to you prior to surgery and says, Doctor, I'd feel so much better if you take this family heirloom into the operating theater with you. I believe this will give you good luck. It's a dried goat's tongue. And you look at it, and it's this dried, oddly shapen, somewhat slimy piece of tissue. What action should you take? Well, wait. Let's be pragmatic here, right? Let's tell her we're going to do it. Tell her we're going to take it in to the operating theater with us. And then we don't really have to, because we'll get all the placebo effect from telling her that we would from actually, no, of course that's wrong. Why? Never lie. You're not allowed to tell patient one thing that's not going to be true. What are you going to do? You're going to take the dried goat's tongue into the operating theater with you. But I'm concerned about, well, this thing is not sterile. Well, that's what plastic bags are for. Put it inside something so it will be sterile and take it in with you. Why? Your patient says it will help them feel more comfortable, and oddly, you'll get a better medical outcome this way. I'm giving you some essentially extreme examples here, but in the hope that you're going to remember this as you go through your exam. Patients ask you to participate in religious rituals, you will participate. Now, to clarify, we will never ask you to do something against your religion. If they tell you that a patient's request is against what you believe, not just not of your belief, but antithetical, against your belief, then of course we won't ask you to do it. If you have someone, for example, who is, let's say, a believer in the Islamic faith or Jewish, and they say, please eat this ham sandwich, of course not. That is clearly against the tenets of that religion. But if it's not of your faith and not against your faith, then of course you will participate. Number 18. Simply reminds you that anything that increases communication is good. That means you want to make sure you have the clear room to have communication, and not just about the patient's health issues, about all aspects of the patient's life. You have to stop and ask what's happening to them in their life at work, in their marriage, with their family, with their children. One really good question to ask all your patients is if they've traveled recently and where they've gone, because often people might pick up something when they travel, and knowing where they traveled really helps with the diagnosis. I'll warn you, if you've not taken the Step 2 CS exam yet, you're going to find this sprinkled increasingly through the patients who are going to see in the Step 2 CS exam. They're patients that have information, places they've traveled, exposures they might have had, and if you stop and you ask in general what's happening with their life, you will get the information and it will help you nail the diagnosis. And if you don't ask those more general questions, if you focus simply on the presenting physiology, then you will simply not get the information and not make the adequate diagnosis. You're supposed to know the patient's physiological properties, their pathological presentation, but also the context in which they have this biological existence. Number 19, be an advocate for your patient. This role is to simply remind you that it's not enough to simply provide for a patient what's readily available. You must obtain for the patient what they need. If there's some procedure we don't do at this hospital, then your job is to find a way to get them to a hospital where they can get the procedure. If there's some medication that's not readily available, your job is to make sure they can find a way to access that medication. If a patient needs a surgical procedure, perhaps, they have no insurance and no way to provide payment for this procedure, your job is to make sure they get the surgery they need, and if they have no money to pay, then this becomes something provided as much as possible free of charge. I know that sounds like idealism and pie-in-the-sky thinking, but I remind you that 85% of our hospitals in the U.S. are not-for-profit hospitals. That phrase, not-for-profit, means concretely that they have to deliver at least 15 to 20% of the care they provide without compensation. Without that, if they don't provide 15 to 20% without compensation, they lose their not-for-profit status. And that means they gain tax liabilities and all the real estate which makes up the hospital grounds. So, even in the real world, we expect you to help patients get the care they need. We don't only want you to focus on providing care for those who pay, but making sure those that can't pay still get the care they need. And finally, number 20. Number 20 is a summary rule once again. Number 20 is to try to once again tie together some of the underlying threads that are woven through the previous 19 rules. See, here's in a nutshell what's so frustrating about the physician-patient questions. Most of you are really focused on getting the right outcome, and good, appropriately so. But physician-patient questions are not merely about getting the right outcome, they're about getting the right outcome the right way. In short, the best answer is not simply getting to the right ends, it's getting there by the right means. The reason why these questions are first confusing is you look down through the options and you see 2 or 3 options, all of which get you to the goal you're trying to achieve. But I'll tell you, only one of them gets you there by the right process. Only one of them gets you there by the right way. How do you decide? How do you distinguish between I got to the right goal versus I got to the right way? That's what the rules are about. Your job here, I remind you once again, is simple. Read down through the presented case. Stop and think about what is the rule that applies for the best possible physician conduct, and then with that rule in mind, pick the option that satisfies that high standard. Keep in mind, ladies and gentlemen, this exam is never about the real. It's always about the ideal. It's never about what actual physicians do. It's always about what the most ideal physician should do under the most ideal of circumstances.